Why should I care about the brain's blood supply? The answer: stroke. When the blood supply of the brain is compromised, a patient will experience what's called a stroke. This comes in at number 5. It used to be number 4 pre-COVID. It's now number 5 because of COVID. In the leading causes of death in the U.S., number 1 cause of adult disability. And just to think about, in a single hour, 80 people in the United States will have a stroke. This is a website, stroke.org, that has great resources for learning more about stroke. But 100% guaranteed you will work with a patient in your medical career who has had a stroke. The public awareness mnemonic for recognizing the signs of the stroke is B FAST, where B stands for balance, so patients might have loss of balance, headache, or dizziness. E is eye, dysfunctional eye movements or blurred vision. F stands for face, so one side of the face is drooping. A is arm, so arm or leg weakness. S is speech, they have either no speech at all or slurred speech, or nonsensical words, or difficulty producing speech. And T stands for time, because time is of the essence, and 911 should be called immediately to get assistance for anyone experiencing these signs and symptoms. We're going to talk about what parts of the brain and what blood supply leads to these different signs and symptoms. So first of all, there are 2 main different types of stroke: an obstructive stroke nicknamed block, or hemorrhagic stroke nicknamed burst. In an obstructive stroke, this is the majority of cases, blood vessel is clogged by either a thrombus, which is a clot, or an embolus, which is a broken piece of clot from another part of the body that has found its way through the circulatory system and gotten lodged in one of the small branches of the cerebral vessels. Regardless of whether it's a thrombus or an embolus, the clot blocks the blood flow to parts of the brain. And when the brain tissue does not receive the proper blood supply, it results in death or ischemia. We'll talk about that in just a moment. The other type of stroke, hemorrhagic, is when the blood vessel bursts. This is less common. A blood vessel bursts and there's bleeding into the brain. The problem is that the blood isn't in the form of capillaries, so there's just diffuse blood all over, but there's not blood getting through the capillaries to provide the proper oxygen. Regardless of whether or not it's an obstructive stroke or hemorrhagic stroke, the brain tissue that is normally being fed oxygen and nutrients by that vessel is no longer getting those nutrients, and the brain tissue will die, or there's ischemia. So what exactly is ischemia? So ischemia is when there isn't enough blood flow to the brain to meet the metabolic demand. The brain is 2.5% of the body weight, but 25% of metabolic demand. In other words, your brain is an absolute hog for oxygen and nutrients. So if there's limited oxygen supply, there's going to be death of brain tissue. Neurons can survive only about 3 to 6 minutes without oxygen before the brain damage occurs. That's not very much time. But importantly, there's a difference between anoxic, which means no oxygen, versus hypoxic, which is limited or reduced oxygen. So even if there's an area infarct that you cannot save, there is an area around the infarct that is hypoxic. That area around it is called the penumbra, and that is typically viable for several hours. And that's why time, again, is so important, because you want to try to save as much brain tissue as you can by restoring the blood flow. You want to try to save as much as you can. And this is why the T here is so important. So how much time do you have? Well, the general guideline is that you have 3 to 4 hours to administer TPA. TPA is tissue plasminogen activator, or the clot buster. This is something you want to apply in the event of an obstructive stroke, but you absolutely don't want to apply it in the event of a hemorrhagic stroke, because you'll cause more bleeding and make the patient worse. So your goal with applying TPA is to save the areas that are hypoxic or damaged but not yet completely dead. So that's called the penumbra. So early intervention with this thrombolysis or clot buster, TPA, you're going to apply. But you need to know whether or not the stroke is due to an ischemic cause or whether or not it's hemorrhagic. And so a CT scan, ASAP, is of utmost importance. If you do a CT scan and you see that the cause of the stroke is hemorrhagic, you stop. Absolutely don't apply TPA. If the infarct is sizable, meaning that the clot buster might cause damage or induce a hemorrhage, you also don't want to apply TPA. If there's other diagnosis, like this is actually a tumor or some other problem, absolutely don't use TPA. Or if the patient has internal bleeding in another part of the body, like gastrointestinal, you don't want to give TPA and make bleeding in another part of the body worse. So it's very critical to make a decision as soon as possible whether or not the stroke is ischemic or hemorrhagic, and whether or not you can apply TPA to open up the block and allow blood flow to continue to the brain. And this is why this public awareness of stroke signs and symptoms is so important, to teach the general public to look out for the signs of stroke and to call 911 ASAP. So where does the blood supply to the brain come from? It comes from two sources: the anterior and posterior circulation. And these terms are really important clinically because you'll hear these terms used in the ICU. Oh, the patient had an anterior circulation stroke, or the patient had a posterior circulation stroke. What does this mean? The anterior circulation arises from the internal carotid, which is a branch of the common carotid. So you can see the common carotid coming off here and heading north to the brain. It's going to give off two branches, which will form the anterior circulation and provide blood to most of the anterior part of the brain. We'll show some pictures of that in just a moment. Posterior circulation arises from the vertebral arteries. The vertebral arteries are a branch of the subclavian, and they also climb up the vertebral column, join together at the base of the pons in this vessel called the basilar, and branch to form the posterior circulation. So any vessels that come from the internal carotid, either pair, form the anterior circulation. Any vessel that arises from the vertebral artery is part of the posterior circulation. You can see this on the CT angiogram. Here's the internal carotid climbing up into the brain and giving off the middle cerebral artery and parts of the anterior cerebral artery that are forming the anterior circulation. This is the view here that we're looking at. So this is anterior circulation. Here is the vertebral arteries coming together and giving this posterior cerebral artery. This is the posterior circulation. We'll show you many more views of this in just a moment. When you look at the base of the brain, you're going to see these vessels form an anastomosis called the Circle of Willis, which is also called the Cerebral Arterial Circle. We're going to learn the names of these arteries and their relationship to different parts of the brain and their clinical significance. So I want you to appreciate this anatomically on the ventral surface of the brain, and you can see this circle here. But then we're going to look at it in cartoon. So this arterial circle is drawn here, and now we're going to convert that into a sketch diagram where we draw all the different parts of the Circle of Willis and distinguish which parts are anterior circulation and which parts are posterior. This is something you want to be able to draw and label. Do it over and over and over again until you've got it memorized like the back of your hand. So let's start with these circles. This is the internal carotid artery, and they're drawn as cross-section because of their spatial relationship. As you can see, these are climbing north and south, right? And so when they get cut, when the brain is removed, you're seeing the cross-section of the internal carotid artery. And they give off two branches, this middle cerebral artery branch and this anterior cerebral artery branch. Remember, these are all paired. So we're going to have one of them on each side. So the internal carotid artery has two branches. There's the middle cerebral artery and the anterior cerebral artery. Then we go to the posterior circulation, which is fed by the vertebral arteries. If you look at the base of the brain, you can see it forms an upside down V. That's how I remember, V for vertebral. These vertebral arteries come together at the base of the pons, also known as the basis. And that's where the name of this artery gets its name, the basilar artery, because it's at the base of the pons. So we go back to this cartoon and you see the upside down V, that's the vertebral artery. That joins to form the basilar artery, and then it splits to form the posterior cerebral arteries. Now it looks sort of like a stick figure, right? The legs are the vertebrals and the arms are the posteriors, and then there's sort of this alien area up here. Okay, now how do we join the circle to form this anastomosis? The circle is formed by the communicating arteries. There's the anterior communicating artery, which joins the two anterior cerebrals. And then there's the posterior communicating artery, or the PCOM, which is a common area of aneurysm. If you ever hear the term PCOM aneurysm, this is where we're talking about. This typically joins the internal carotid artery to the posterior cerebral arteries. And now we have a circle. So to review really quickly, we have three internal carotid branches. There's the anterior cerebral artery, the middle cerebral artery, and the posterior communicating artery, which are all coming off of the internal carotid. There's also, if you want to organize this in terms of the three cerebral arteries, we have the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. But remember, posterior cerebral is not a branch of the internal carotid. It's a branch of the basilar, which is fed by the vertebral artery. So this is all going to go into the posterior circulation. So this is providing blood for the brain. What about the cerebellum and the brainstem? We have cerebellar arteries that do that. There's 3 of them. There's the superior cerebellar artery, which comes off of the basilar. There's the anterior inferior cerebellar artery, nicknamed ICA, coming off of the basilar as well. And then coming off the vertebral is the pica, posterior inferior cerebellar artery. These, SCA, ICA, and pica, are providing blood to the cerebellum and the brainstem. In another lecture, we'll talk about the blood supply of the spinal cord, but I'll just make a note here that the anterior spinal artery is coming off of the vertebral artery and joining together to travel along the anterior surface of the spinal cord. We'll discuss that in another lecture, along with the posterior spinal arteries. Lastly, there's these pontine arteries. These are smaller branches that are coming off of the basilar to provide blood to the anterior portion of the pons. So let's look at the territories where these vessels travel. So if you look at the brain, this is the sylvian fissure, also known as a lateral sulcus, and this middle cerebral artery travels along the sulcus and then branches all throughout to provide blood to the lateral portion of the brain. This is the territory of the anterior cerebral artery. It's going to come in here to the medial. This is a mid-sagittal cut of the brain. It's traveling here at the junction between the cingulate gyrus and the corpus callosum, and it's providing blood to the more medial anterior portion of the brain. And then the posterior cerebral artery, you're going to see branches of it along the brainstem and all. It's serving the inferior portion of the temporal lobe and also this medial occipital lobe. Your primary visual cortex is back here, which is being fed by the posterior cerebral artery. So as you can imagine, ischemia in the posterior cerebral artery is going to cause blurry vision in the contralateral half of the visual field. This is something you absolutely want to memorize. You'll be tested on it the rest of your life. The cerebral artery territories are color-coded here in this pastel blue, which is the territory of the anterior cerebral artery. So here's the mid-sagittal view of the brain. This is the anterior medial surface, and a little bit dipping over. The pastel pink is the MCA territory, middle cerebral artery, and the PCA, or posterior cerebral artery, which is this occipital lobe laterally, occipital lobe medially, and a little bit of the inferior and middle temporal lobes. Okay, so now I'm going to take a little aside and give you a memory trick for remembering the territory of anterior cerebral and middle cerebral arteries. If you take your hands and put them like this is as if you're covering your ears and holding your head. It's so much information to memorize. Your hands are the territory of the middle cerebral artery. They're the lateral and anterior portion of your brain. The anterior cerebral artery is like a mohawk. So take your hand and go like this. Ready? Mohawk, mohawk, anterior cerebral artery. Posterior cerebral artery, take your hands and cup your occipital lobe, right? Posterior cerebral artery, all right? So MCA, ACA, and PCA. Okay, time to return to the PowerPoint. So what about the blood supply of the brainstem and the cerebellum? So here we're looking at a mid-sagittal view of the brainstem and the cerebellum. And here are those 2 vertebral arteries that are coming up and joining to form the basilar artery going over the base of the pons. Right? We have the superior cerebellar artery going to provide blood to the superior portion of the cerebellum. And then there's ICA, which is anterior inferior, right? And then there is pica, which is posterior inferior. But as SCA, ICA, and pica travel, they're going to provide blood to the brainstem as well. Key feature here is that arteries that are along the midline, such as the basilar, vertebral, and the anterior spinal, are going to provide blood to the medial portion of the brainstem, whereas these lateralized arteries, the PCA, ICA, pica, and posterior spinal, are going to provide blood to the lateral brainstem. This is why you can get 2 different types of brainstem syndromes, whether or not it's a midline artery or a lateralized artery that is ischemic. Here is the cerebellar territories where you can see the SCA here. And what you're looking at is a posterior view of the cerebellum. This is superior, inferior. It's as if you just took the cerebellum off and plastered it onto this piece of paper here. And this is a medial. This is as if you're looking into the patient. So this is looking at the back of the patient's head. This is looking from the front. and you've removed the brain and the brainstem, and you're looking at the anterior portion of the cerebellum, right? So it makes sense that ICA, anterior inferior cerebellar artery, is more anterior, PICA is more posterior and inferior, and SCA is more superior. So now comes the clinical significance and why knowing the anatomy of those vessels can be so powerful in localizing a cardiovascular lesion. So let's take this question right here. What part of the body would be affected from a stroke here? So hint, first, think about what part of the brain am I at? I'm in the lateral cerebrum. So which cerebral artery am I in? All right. If you remember, the territory that feeds this part of the brain is the middle cerebral artery. This is our left hemisphere of the brain. So this must be the left MCA, the left middle cerebral artery. So what does that mean about what part of the body and the patient would be affected? Well, first of all, we have a couple of principles that we must know in order to solve this problem. The first one is that each cerebral hemisphere controls the contralateral side of the body. So in this slice, this is the right hemisphere that we're looking at. We'll pretend that we're looking at this with classical MR or CT scan orientation, which is opposite. So we're looking at the right hemisphere. That means that the left body is represented in this part of the cortex. Over here is the left hemisphere of the brain, so that would be the contralateral or right body. The next principle is that the homunculus is similar for the somatosensory strip and the motor strip. Well, what is the homunculus? The homunculus literally means little man, and it's a body map in which the size of the different parts of the body on this model represents the amount of surface area of cortex devoted to processing that part of the body, either processing it from motor control perspective or a somatosensory sensation perspective. Here what we're looking at is the homunculus mapped onto the somatosensory cortex, which is here in this red-orange color. And the different parts of the body are mapped on and occupy different, you could say, real estate, different parts of the surface area of the cortex. So if you notice, the face area is mapped laterally, and so is the arm, whereas on the midline is the lower limb, the feet, and the genitals. So what does this mean in terms of stroke? That means that strokes of the lateral cerebrum, in other words, the MCA, will affect the face and the upper limb because those parts of the body are mapped onto certain surface areas of the cortex. Whereas strokes of the medial cerebrum, which is fed by the ACA, will affect the torso and lower limb. Another important point about the homunculus is that you get more cortical surface area for body regions with either the highest sensitivity or the finest motor control. What do you think that is for the human? It's the hand and the lips, both for the motor cortex and the somatosensory cortex. So you're going to have a homunculus for the somatosensory cortex. You're also going to have a homunculus for the motor cortex. It's so well organized and so beautiful. I'm going to escape here so you can see. So here's the left hemisphere. So we have the right face mapped here, the right arm, the right hand, the right arm, and you can see that there's a disproportionate large amount of cortical surface area devoted to the hand and the face and even the lips compared to the other body parts. If you look at a mouse, the homunculus of a mouse is mostly whiskers. There's an enormous amount of cortical surface area devoted to the whisker in the mouse. So it's the area of finest motor control or highest sensitivity. So let's go back to this question. We figured out that the artery feeding this part of the brain would be the left MCA. I'm specifically pointing to the somatosensory cortex here, but the motor cortex, which is anterior, here's the central sulcus, would also be affected by the left MCA stroke. And so if this is the left MCA stroke, we know that it would be the right body. And we have to choose, would it be arm and face or would it be lower limb? In this case, the homunculus is mapped laterally, arm and face. The left MCA stroke is going to cause contralateral right arm and face deficits. This knowledge of this homunculus and knowledge of the territories of the vasculature give you enormous amount of power in diagnosing location of the stroke, in determining the location of the stroke. In fact, neurologists can determine the location of the stroke just by observing the patient before they even do order imaging, and the imaging is done for confirmation. Here's a CTA, a CT angiogram of the Circle of Willis, and you can actually see an area here of ischemia in the middle cerebral artery. I'm not sure exactly, but I want to point out to you, there's the vertebral arteries, the basilar, posterior cerebrals. Here's the internal carotid branching into the middle cerebral artery, anterior cerebral artery. You can even see the anterior communicating. I see a nice posterior communicating on this side. I don't see the posterior communicating on this side. Sometimes it's absent in individuals. I don't know enough about, I don't have the patient history on this image, but it gives you a sense of appreciation of these vascular territories. All right, let's try another practice question. What part of the body would be affected from a stroke here? Well, first thing you should answer is which cerebral artery is this? We're looking at a midline, mid-sagittal cut, medial view of the brain. This is left hemisphere. So the artery providing this mohawk area is the left anterior cerebral artery, left ACA. So we know that for what part of the body would be affected, left or right? It would have to be contralateral body. If this is the left hemisphere, it has to be right body. And now we have to decide, is it lower limb, face, or arm? This most medial portion is where the homunculus map of the lower limb is found. So this would be contralateral or right lower limb due to a left ACA infarct. Okay, two more important points to remember about stroke. Strokes of the left hemisphere usually cause aphasia, and strokes of the right hemisphere usually cause, in addition to the limb deficits, neglect. What are aphasia and neglect? What are aphasia and neglect? Let's start with aphasia. Aphasia is a loss of ability to produce or comprehend language. And these come from the language areas which in 90% of the population are mapped onto the left hemisphere. Most of those 90% are people who are right-handed, although not all. And many of the people who have language, the 10% of people who have language mapped onto the right hemisphere, many of those tend to be left-handed, although not all. There are some trends, but it's not an absolute. There's an enormous diversity in individual brain mapping. So the majority of our patients, 90% of them, are going to have language mapped onto the left hemisphere. There's this lateralization of function. The area that is important for the production of speech is called Broca's area, and it's in the frontal lobe. The area that's important for the comprehension, making sense of the speech, making sense when you make it, making sense when you understand it and listen to it, comprehension of language, is Wernicke's area. It's here in the temporal lobe. So people who have damage to either Broca's area or Wernicke's area will have difficulty with either producing speech or comprehending speech. So here's an example of a patient who wants to say the dog needs to go out and I'll take him for a walk. A patient with Broca's aphasia would have difficulty spitting out the words. They might get certain parts of the word. Dog, walk, take, and usually the patient has knowledge of this deficit, and they're very frustrated because if they don't have damage to Wernicke's area, then they have language comprehension in their mind. They just can't spit it out. Now, there's nothing wrong with their tongue. There's nothing wrong with the muscles in their mouth. There's nothing wrong with their vocal cords. All of those muscles are intact and are functional. This is the brain's production of words and producing those words into language. Now, in contrast, somebody with Wernicke's aphasia typically does not have awareness of their deficit because they're having a deficit with the comprehension. So instead of saying the dog needs to go out and I'll take him for a walk, they'll say, you know, that Smoodle Pinkard, and I want to take him around to Tupelo and take care of him like you want before. The nickname for this type of language is called word salad. They typically have very good intonation of their voice. They have the musical quality of speaking, but it's nonsensical. And they oftentimes make up words, such as a Tupelo in this case. These patients are typically not as bothered by the deficit because they don't have awareness, often don't have as much awareness of the problem. Now, there's a white matter tract that connects Broca's areas to Wernicke's areas. It's called the arcuate fasciculus, and it forms this sort of arched pathway. And patients who have damage to arcuate fasciculus have conduction aphasia. In other words, they can understand language and they can produce language, but they can't connect these two areas. So if you ask them to repeat back to you, they can't do that. So they can hear it, but then they can't connect to repeating it back to you. Patients with all of these areas damaged would have something called global aphasia. So remember, Broca's aphasia is production of language, Wernicke's aphasia is comprehension of language, and conduction aphasia is no ability to repeat back. And interestingly, patients who have their language is in the form of sign language, and they've been signing as a form of language their whole life, will have, if they have a stroke to the left hemisphere, they will typically have right arm and face weakness, that contralateral body deficit, as well as either Broca's aphasia in signing. So they will try to produce the signs with their hands, but they can't make their signs form. It's not a problem with paralysis that they have difficulty producing the signs. If they have a Wernicke's aphasia, damage to Wernicke's area, they will make word salad sign language. If they have conduction aphasia, they won't be able to repeat back signs. So it doesn't really matter what form of language they use. This is the brain's processing stations for language. All right, let's talk about neglect. So visual spatial neglect is caused by damage to the right parietal cortex, especially in the right hemisphere, and it causes neglect or lack of awareness or attention to the opposite half of visual space, but visual thresholds are near normal. So this is not a vision problem. Their retina is intact, their optic nerve and optic tract are intact, their occipital lobe, primary visual cortex are intact. This is the brain's awareness that is certain that the contralateral half of the visual field is there. And this is typically in the right hemisphere, and it causes neglect of the left world. When you ask a patient with visual spatial neglect, a right parietal cortex stroke due to the right MCA, to draw the house, you show them this picture and you ask them to draw what they see, this is what the picture will turn out as. They just lack awareness, that they neglect the left visual field, the left visual world. If you ask the patient to put an X mark through every stick that they see, this is what they will draw. They neglected this left half of the visual world. Now, why do patients only have left visual spatial neglect from right hemisphere strokes? The left visual world is mapped onto the right hemisphere, but the right visual world is mapped onto both sides, and so there's redundancy. And so patients typically don't get right visual spatial neglect. This is something you typically only see with patients with a right hemisphere parietal stroke causing left visual spatial neglect. The neglect is what the patient's seeing in the world. Awareness is the left neglect, meaning that they're neglecting the left part of the visual world. So let's do one more practice question. A 65-year-old female with cardiovascular disease arrives to the ED unable to speak with right facial droop and right arm weakness, which is the most likely location of the stroke based on these symptoms alone. Right ACA, left ACA, right MCA, left MCA, right PCA, or left PCA. Right off the bat, from this lecture, you should be able to notice this unable to speak. Sounds like Broca's aphasia, that must be in left hemisphere. That is in line with right facial droop and right arm weakness. It's the left language area, meaning left hemisphere, contralateral body, and we know that the face and the arm area are in the lateral hemispheres, which is fed by the MCA. So right off the bat, bam, you can make pretty good guess that this is the left MCA infarct. So when we go back to this public awareness, we can see that the B fast really represents strokes of different vasculature. Balance, loss of balance, headache, and dizziness is most often a symptom of the posterior circulation, one of the vertebral arteries, so potentially something in the brainstem or a vessel feeding the cerebellum, which is a center, which is important for their balance. Eyes, blurred vision. Remember, posterior cerebral artery provides blood to the occipital lobe where the primary visual cortex is located. So blurred vision is typical in a posterior circulation. So B is posterior circulation, and F, facial droop, arms, or speech, is common in anterior circulation stroke. Regardless of the type of stroke, anterior or posterior, time is of the essence. Call 911 and get the patient into a CT scanner